Welcome to our sixth Trauma Anesthesiology Society podcast. I'm Dr. Joshua Sappenfield, and I'm here with Dr. Kevin Blaine. Thank you, Doc Matters, for hosting. Today, we're going to talk about REBOA, which has been a pretty awesome intervention in the setting of hemorrhage. On my panel today, I have Doctors David Bracco, Andy Milne, and Steve Smith. We're interested in specifically in the anesthetic management when a REBOA is in place and whether anesthesia providers should be trained to place them. Dr. David Bracco is an associate professor in the Department of Anesthesia at McGill University and Montreal General Hospital. He specializes in critical care and trauma in his department, and he is his department's point person for REBOA. He's probably placed about 20 REBOA devices in the last 1 to 2 years. Dr. Andy Milne has completed anesthetic training in London and has spent an extra year doing trauma anesthesia fellowship at UCSF back in 2016-2017. He is currently working in London's air ambulance, where they've been doing Zone 3 REBOA placements in the pre-hospital phase for about 5 years, and they're about to start Zone 1 placement in an observational study. After his secondment, he'll be working as a consultant with the Royal London, where he'll be involved with trauma patients receiving REBOA, again, as part of anesthesia group. Dr. Stephen Smith is a professor of surgery and trauma and a medical director as the trauma medical director at the University of Florida. He was a member of the American College of Surgeons Committee for Trauma for 19 years. He was an early adopter of REBOA in the setting of trauma and emergency surgery, and he has 5 years experience for REBOA. Dr. Smith and his colleagues at the University of Florida have published 3 peer-reviewed articles regarding REBOA. Dr. Smith and his team have trained numerous surgeons and residents in the indications and performance for REBOA. Additionally, Dr. Smith served in the Medical Corps of the United States Navy as a reservist and retired as a rank of captain.
Hey, great, thank you. Let's just jump right into it first. So many of our listeners may not be familiar with REBOA, although several of them are. I wonder if we can talk a little bit about what it is and when it's useful. So Steve, you're a trauma surgeon and you're very experienced with this device. Would you mind summarizing this concept and its surgical indication for our audience?
Sure. It's actually a pretty straightforward technique based on some vascular or endovascular techniques. It essentially involves placing a catheter with a balloon at the tip of the catheter from the common femoral artery, and there are techniques to advance it over a guide wire and without a guide wire, upstream to a location in the aorta where the balloon can be inflated. And this does a couple of things. It inhibits forward flow of blood at that point when the balloon is fully inflated, and it also increases the blood pressure proximal to the inflation point to preserve perfusion of the brain and the heart. It, in effect, when placed at Zone 1, is roughly equivalent to the hemodynamics effects of placing a vascular clamp on the supraceliac aorta. Zone 1 is basically in the region of the diaphragm from the subclavian distally down to a point just proximal to the visceral arteries. Zone 2 involves the visceral arteries. The balloon is not inflated at that point. Then Zone 3 is, in effect, the area of the bifurcation of the aorta. And this Zone 3 is where the balloon would ideally be placed if you have bleeding from a pelvic fracture or lower extremity fractures, or in this particular case, bleeding from the uterus. It's not a new technique. First described in 1953, a case series of 3 patients by Dr. C.W. Hughes, who used it in the Korean War. But all of those patients died, so it was kind of forgotten until about 10 years ago, at which time a lot of interest was generated based on moderate endovascular surgery. And a number of series have actually shown that it's a benefit to control hemorrhage and to improve hemodynamics in patients with injuries below the diaphragm. And most trauma centers have the ability to place the REBOA in a select group of patients.
David, Andy, do you guys have anything to add?
No, this is a quite good summary of what we do. Yes, it's not a new technique, has been tried in the Korean War, went back through vascular surgery, and now is a little bit more expanded among the trauma world due to more simple balloon and smaller insertion devices. But very good presentation.
Yeah, I have nothing to add to that. That's a good summary.
Well, that was very helpful. So, David, you're the REBOA troubleshooter for your shop. Can you walk us through how a REBOA is deployed?
So we have REBOA kits, I would say, in the trauma bay, which is roughly getting access in a common femoral artery with a 7 French introducer. We use standard 11 centimeter 7 French introducer from electrophysiology lab, actually. And we have the Prime REBOA, which is a 6 French balloon, wireless. And it's quite stiff. It's not so easy to deploy, but it's a quite of low profile in terms of deployment. We deploy them completely blindly. And I would say the indications are almost classical. When we have a bleeding abdomen, very unstable, we go zone 1 blindly based on femoral to xiphoid to sternal notch distance, like an aortic balloon pump. And if we have something below pelvis and below, we deploy zone 3. We use it often, I would say, on very bad leg injury, completely crushed leg, non-compressible, open femur fracture, where there's a 2-liter hematoma, and we're pretty happy with that.
But that kind of actually raises an interesting point. So you're placing them blindly up in Montreal. What are you, Steve, and Andy doing?
We're landmarking in the pre-hospital environment, so yeah, sternal notch, mid-sternum balloon sort of level for zone 1, although we're training in zone 1, we haven't actually deployed zone 1 yet, and then umbilicus for zone 3.
Josh, we on occasion will place these based on anatomic landmarks only, but prefer to use imaging to identify where the location of the tip of the catheter, where the balloon is, actually rests, because I think we're going to address this later. It's not necessarily a completely harmless procedure, and inflation of the balloon in zone 2 could be problematic and could cause injuries to some of the major visceral branches. So we very much prefer to have imaging to confirm the location. This is particularly true if you're using the 12 French coda balloon as opposed to the 7 French ER REBOA. Sometimes obviously that's not possible, and you have to do it based on anatomic landmarks, but we prefer to use imaging as soon as possible to confirm position.
I just remarking that I think the 1 or 2 that me and Steve done together was in the trauma hybrid room, and we used imaging for those.
Right, that's a great location for REBOA when you have a hybrid OR. Obviously, that's going to be not the majority situation for placement of REBOA, however.
And just to be clear, your imaging modality, you're using fluoroscopy.
We currently use fluoroscopy preferentially. If you can't do that, a simple static image of the abdomen to identify the location of the device is certainly acceptable. And I know that that's being done in many trauma bays.
Sorry, David, in Montreal. Actually, some of them, we place them in the operating room if we have time, in protection of our opening laparotomy. What we have done on very unstable patient, we go with the ultrasound through the liver, detect the descending aorta, and when we see the balloon passing by, we push it 10 centimeter higher.
So, David, what's different about intraoperative management of a patient on the table when the REBOA is inserted?
Oh, that's very complex in the sense that you have huge hemodynamic changes, like when you do an descending aortic thoracic aneurysm and you clamp and clamp. So you have to be prepared, and we do really a stage unclamping. We deflate the balloon cc by cc. We look at what's happened. We look at the recirculation. We look at the lactate circulating through. But and you cannot stay forever on a zone 1 balloon. You have all spinal cord ischemia and abdominal organ ischemia. So as soon as the abdomen is controlled, we go from zone 1 to zone 3, or we try to deflate.
So this sounds like a very fantastic technology. I'm sure it has absolutely no contraindications or complications whatsoever. Of course, I'm being sarcastic. It actually sounds like there's a lot of things to consider here. You know, we're choking up blood flow through to most of the body. So Andy, I wonder, what do you think we need to watch out for when we're inserting this, and how should we be careful, or what should we be careful of when we're using it?
Yes, thanks. Well, as with any medical procedure, there are complications associated with REBOA deployment. Now, these can be broadly categorized into issues associated with the arterial access itself, the balloon positioning, then balloon inflation, and finally balloon deflation. So the arterial access procedure itself can cause direct trauma to the femoral iliac vessels, such as dissection, rupture, or even the formation of pseudoaneurysms and AV fistulae. The sheath itself and the catheter can cause emboli, which break off and obviously cause distal ischemia. And even the access itself, the sheath, can cause a reduction in blood flow distally. So that's at London Hems, and I think most places are inserting a sort of smaller 4 French sheath in initially, and then upsizing to an 8 French sheath when it's sort of confirmed that we are deploying REBOA, unless, of course, it is a very much barn door case for REBOA. And malpositioning of the balloon, either by ending up in a little tributary coming off the aorta, or by just missing the landing zones, will result in either failure of the procedure to improve hemodynamics, or even quite severe vascular damage. Yeah, so balloon inflation should be done with care. Zone 3 shouldn't require any more than 3 to 5 mils, and zone 1 shouldn't require any more than about 8 mils to fully inflate the balloon and to achieve complete REBOA. If resistance is felt and no improvement in hemodynamics, with only a small volume, then you could well be in a tributary. Aortic damage has occurred previously as the balloon goes up, and balloons have also ruptured, leading to sort of precipitous hemodynamic collapses. Once the balloon is inflated, you are resulting in a sort of a near total ischemia of the tissues distal to this. And so complete REBOA or C-REBOA should be minimized to the absolute minimum of time, and aiming for a partial REBOA, so slightly reducing the volume of saline in the balloon and allowing some runoff. At London Hems, we're trying to limit our C-REBOA time to no more than about 20 minutes.
I agree with what was just said, with a couple of minor variations. Remember that if you inflate the REBOA and the patient happens to be bleeding proximally to it, that will actually increase the bleeding. So you want to make sure that if you're in zone 1, you don't have a chest injury, and if you bring it down to zone 3 and you raise the blood pressure proximally, you actually might increase bleeding of an injury proximal to the insertion site. Pseudoaneurysms, I think, are something that need to be considered. If you use the 12 French device, and most of us are not using that anymore, every one of those required an open repair of the arteriotomy. But even with the 8 French introducer, probably about 50% of those patients, if you look carefully, will have some vascular complication, either a thrombus formation or more commonly a pseudoaneurysm that would need to be repaired to prevent further complications. The concept of the balloon tip actually going out in one of the visceral arteries is a thing that concerns me, particularly with the smaller devices without imaging, because you could make matters markedly worse if the balloon were in the celiac artery or the SMA, and that vessel was ruptured upon insertion. And the one last point I want to make, that from my standpoint, we don't really use a set amount of volume in the balloon. We're looking at the hemodynamics of the patient. Obviously, you can't overinflate the balloon, but I'm looking at the art line tracing to see what the hemodynamics are doing, and generally stop inflation of the balloon when the hemodynamics are better. Partial REBOA, I hope we have a chance to talk about that. That was just brought up because I think as we go forward with this technology, that's the wave of the future.
There's one more aspect to the complications that I just wanted to mention as well. So balloon deflation, this is especially pertinent to us anesthetists in the OR. So it's as you take down the balloon, you can have quite a profound ischemia reperfusion hit, very similar to the reperfusion during liver transplant, or to a lesser extent tourniquet deflation after a long limb operation. This results in a big flood of blood high in potassium, vasoactive agents such as nitric oxide, and inflammatory mediators, which can sort of lead to arrhythmias and even quite severe vasoplegia.
Yeah, for some of that reperfusion, when Steve and I have done together, we have done a partial inflation, and I think that would be a great time for Steve to talk about it a little bit.
Sure, it's been brought up previously and well described, I think, but just to reiterate, once hemodynamics have been reestablished, you certainly don't want to leave this balloon creating distal ischemia up for any longer than you have to. And kind of an intermediate approach, if you will, is as the resuscitation has progressed and as the patient has been, his volume status or her volume status has been improved, you can gradually decrease the inflation of the balloon to maintain some occlusion and some increase in SVR, while at the same time allowing distal flow to minimize the period of ischemia. And there's work being done, and I don't believe this is commercially available yet, but there's work being done on small computer modules that could be attached to the REBOA that would actually do this automatically based on patient blood pressure and other inputs. But I think that's an important thing to remember. Don't leave the balloon up forever. Begin deflation incrementally over a period of minutes. Because if you just take the balloon down suddenly, you will have some noticeable changes in hemodynamics.
And I agree with a nice classification of issue and complication possible. I would say on our arterial access issue, yes, this is a very critical part. In our series of about 30, 40 REBOA, we had only one where we had to go surgically. It was in a morbidly obese patient, where the entry point was in the SFA due to the abdominal, fat. So we were too low, and this led to having to go surgically to repair the artery. Yes, in terms of arterial access complication, we close all our access on an angioseel. We have no issue. We had one complication where the entry point was in SFA in a morbidly obese patient, where the bifurcation was well below the abdominal fat pad. In terms of balloon position, yes, going in a tributary artery is a big issue. The only problem I find is that the only way to know where you are is your feeling on your finger. And as you said, don't inflate with a fixed volume, inflate progressively and feel a balloon. You'll feel at some point when you are near occlusion, the arterial pulse hitting the balloon. When in terms of deflation, I agree, we deflate them very progressively, very slowly, and we look at the hemodynamic, half a cc by half a cc.
Steve, now you mentioned this topic of partial inflation of REBOA, and I found this to be a very interesting topic myself. One approach would say that any blood flow that gets past the occlusion should contribute to oxygen delivery to the distal tissues. Another approach might be that if you're pushing a hypotensive or a small amount of blood flow, you may not be reaching the tissues you want. If you have an arterial bleed, it might be going straight out on the field. I wonder about the evidence that supports using, or the thought behind using partial partial inflation?
There are some some interesting animal studies that have looked at survivors of P-REBOA, and basically what's done is the REBOA is fully inflated to achieve hemodynamic stability initially, and then the amount of inflation of the balloon varies to some degree based on how the hemodynamics progress. And again, in some of these animal studies, it's done with a computer module that will do this automatically for you. I think that none of us are going to have time as we're operating or resuscitating a critical patient to, take a half cc in, put a half cc in the balloon. But if it's done via a computer-controlled module, it makes some sense. And in those animal studies, it appeared that partial REBOA, that technique which I just described, had a survivor benefit in a statistically significant fashion compared to complete REBOA for the entire duration of the resuscitation. And again, these are some fairly preliminary studies. I know some people are working on this with a great deal of vigor. But the initial animal studies appear to offer some survivor benefit.
No, I think we covered not all, most of the issue and possible complication and pitfall. We leave someone, if we go put a REBOA, for example, in a bleeding abdomen, and we go for laparotomy, we leave a person dedicated to the REBOA. So his only job is watching the REBOA. No one is pulling it out. And when we ask to inflate, deflate, etc. So we dedicate one person to the REBOA in the surgery.
May I ask who that is? Is that a member of the surgical team or the anesthesia team?
Usually it's a member of the surgical team, is one of the surgical residents, usually a junior surgical resident, so they can stay in the field, look what's happening, but they have the two hands on the balloon, on a catheter.
Well, so we talked about some of the evidence for partial inflation of REBOA. How robust is the evidence for just REBOA in general, Steve?
Well, again, there's been a great deal of enthusiasm over the last decade, and most of the initial reports showed a benefit to REBOA as far as survivors, the percentage of survivors compared to ED thoracotomy. I have to be honest, from the outset, there was criticism of comparing those two groups of patients as not being exactly the same, comparing apples and oranges. And I think that's a valid criticism. Despite that, I think most trauma centers, again, move towards developing REBOA protocols and having it available. Something that really invigorated the discussion was a paper by our friend Bilal Joseph at the University of Arizona in 2019, based on a fairly small data set from TQIP, the Trauma Quality Improvement Project, that actually showed worse outcomes with REBOA, decreased survivors and more renal failure and more extremity vascular complications. And again, frankly, this study has, although it stirred up the debate, has been criticized as potentially having selection bias and not comparing patients that were truly identical or even comparable. But I think it brings up some interesting points. While REBOA is a good tool in the trauma setting, the precise indications are still being worked out. And again, while it's being used very frequently, I think this paper in particular threw a little bit of a wet blanket on the upward trajectory of REBOA, and has caused us all to consider if we were doing it in the most appropriate circumstances.
Thanks again. So I'm dying to know about different practice patterns, which is why I'm glad we have 3 panelists here from 3 different countries. It seems like anesthesia providers are not always involved in the decisions about REBOAs, at least not everywhere. I mean, I practice in the United States, and while I can and frequently do make recommendations to the surgeons about when to insert a balloon, when to inflate it, and when to deflate it, by no means do I myself place it or manage it. But in Europe and Canada, it sounds like anesthesiologists are involved in different ways. Andy, in the British system, who places and manages REBOAs?
Well, even within the UK, there's quite a lot of variation in practice. So some, even among the major trauma centres in London, there's some that don't do REBOA. But in the pre-hospital phase, REBOA is deployed and managed by the pre-hospital care team. So that's one physician, sometimes two physicians, plus a paramedic. We would then transfer the patient to the nearest major trauma centre and hand over the patient. If the team there is comfortable with REBOA and happy with its management, then we'll let them take over. But if we end up in the major trauma centre that's not comfortable with REBOA, we would have to accompany the patient to theatre or IR and continue the management ourselves. In terms of in-hospital, if it's deployed in-hospital after the pre-hospital phase, it is typically the trauma team lead and the trauma surgeons. So they're typically ER docs or trauma surgeons, obviously, that lead the placement and management of REBOA catheter, but in close partnership with the anaesthetists on the trauma team. And so they have input from anaesthetists, but it's not typically us that leads it in the in-hospital phase.
Well, that sounds like a big commitment. Dave, how about in Montreal? What's your practice? Who owns REBOA there?
Yes, so in terms of who own the REBOA in Montreal, there's, I would say, two groups of people, some trauma surgeon, but a handful of trauma surgeon, and some trauma anesthetists. In the anesthesia group, we're 16. We have 5 of them who are ECMO trained and certified, and these one put REBOA in. In terms of certification, we do in-house training for ECMO team, and you have to be supervised and watched and are so-called certified by interventional radiology as being able to access safely the CFA. And this is done by in-hand training, and they have to sign that you are capable of accessing a CFA. But roughly 5 trauma anesthetists and 3-4 trauma surgeons in Montreal.
Wow. Steve, now you're in the United States and you're a surgeon. Does it make you squeamish when you hear anesthesiologists talking about placing REBOAs themselves?
In the United States, the vast majority of REBOA insertions and related procedures are performed by surgeons, someone with a surgical background, a much smaller percentage of emergency medicine physicians are doing this without surgical participation, and I guess there's a smattering of other people. But to answer your question, in honesty, it does not give me a great deal of angst having non-surgeons place REBOA if they are adequately trained, and it sounds like we have some excellently trained folks on this call. And actually, if you look at the history of this, our Japanese colleagues have been doing this really longer than any of us, at least in the modern era, with very large series and good results. And the vast majority of those REBOA catheters in Japan were placed by non-surgeons. So I think it's, there's a great deal of overlap in training now. If someone is adequately trained and has a good protocol and backup, it doesn't cause a great deal of heartburn for me. Although I think from a credentialing standpoint, at least in the United States, non-surgeons doing this would be met with some fairly robust debate and opposition.
So everyone, I guess, except maybe me and Kevin here, has undergone some specialized training for REBOA placement. Andy being the most recent. Andy, what was involved with your training for placing REBOA?
So I was trained in REBOA as part of the sign-off process for London HEMS, and so we have sort of multiple modalities of training covering various topics. Initially there's a 2-day course called the Pre-Hospital and Emergency Departments REBOA course, peer course, which covers a lot of the backgrounds, anatomy and physiology into REBOA, plus indications and practicalities of deployment, and it's quite hands-on. Then we incorporate REBOA quite a lot into our sort of regular moulages, in which we do sort of relatively low fidelity simulations, which help cover troubleshooting, when to bail on an attempt at REBOA, which is quite an important aspect. And we're also expected to read up on a reasonable amount of the background literature, the key papers, and then we're all tested prior to being signed off as REBOA competent to go out and do it in the field. So any training really should cover theoretical knowledge, evidence behind things, slow time practical scenarios, and then especially with kit familiarization, and then fast time simulation and moulage.
Dave, what did you do to undergo training for this?
Personally, what we did in-house at the Montreal General Hospital, this is not a Canada-wide situation, but we were one of the first centers to introduce REBOA to make it safe. We had a whole bunch of theoretical training, case-based training. We have an ECMO dummy simulator, which we can use for REBOA access and training, since it has 2 CFA and a descending aorta in plastic. A very low fidelity system, but it helps you with this. And as I told you, you have to be so-called certified by interventional radiology as knowing what to do with catheters, wire, 7 French, etc. So having this framework, we have 3 trauma surgeons who are certified. One of them is a military, Andrew Beckett, and 2 of them are our trauma surgeon and 5 anesthesiologists. But the 5 anesthesiologists are on the ECMO team, so they are used to access the CFA quite rapidly, understand the ultrasound image, ultrasound guided access, etc. We do all our ultrasound, all our accesses ultrasound based. There's no way we poke blindly in a femoral artery. We have make sure we go in the CFA, we go on the roof of the CFA, and this is part of the most critical part of the training.
And Steve, I heard you went up to RM's Cali shock trauma for your training.
That's partially true, Josh. I have some very basic endovascular skills, through the practice of trauma surgery, but had not really done a REBOA. I received outside training in a couple of ways. I attended an introductory course at the Eastern Association for the Surgery of Trauma with simulators several years ago. And then to be a little bit more familiar with the technique in a cadaver model, I went to Baltimore to the shock trauma unit and attended an excellent 8-hour course with a pressurized cadaver model that was really incredibly well done. Megan Brenner and Melanie Hain put that together, and I thought that was a very inclusive course with lots of hands-on experience. And once I did that and started the program at our hospital, I found it unreasonable for all our faculty to go off campus to one of the more extensive courses. So we had a mini course, if you will. Again, these are very experienced surgeons, one of whom has a vascular fellowship background. So we did lectures, we did scenarios, and we did simulation to get the program started in our place with the full support of our vascular surgery team, because we knew there would be some complications and we wanted them on board. And then yearly, we have some overview and simulation courses for the residents and fellows that are entering the trauma service. And we have incorporated a REBOA module into the ASSET course, which is a surgical vascular exposure course that's put out by the American College of Surgeons. And again, that's a cadaver course, and that worked quite well.
Now, in my neck of the woods, we don't usually have physicians on ambulances. It would be exceptional if we did, but I know that's different in a lot of other parts of the world, maybe even most parts of the world. Andy, since this is your wheelhouse, what sorts of concerns are specific to pre-hospital REBOA?
Yeah, so in the UK, we have a model somewhere in the middle between the US and the EU. So in the EU, there's a lot of physicians on the ambulances, and obviously US, there's none or near none. And then we sort of sit in the middle with just a few teams covering sort of specific catchment areas. So there's only one of us for the whole of London, so covering 6 million people. And we're almost entirely trauma-based, and so we see a lot of it. The challenges specific to pre-hospital REBOA, main things are potentially unnecessarily prolonging the scene time. So we only perform REBOA if we feel that the patient will die from exsanguination prior to their arrival in the ER, or if they get to the OR. And even just persisting at attempts at REBOA when it's becoming clear that it's not going to be successful. I think that can greatly prolong your scene time. And then other challenges include like the relative lack of personnel. So in the pre-hospital phase, we have maybe 2 or 3 trained personnel amongst the HEMS team, plus a few standard London Ambulance Service paramedics who aren't trained in REBOA. So these 2 or 3 trained personnel will have to perform to provide an anaesthetic, get wide-bore IV access, give blood, and deploy REBOA in these patients. And so it can be very challenging to get your prioritization right, whether you need to get REBOA in immediately or whether it's better to get IV access, give blood, and then deploy the REBOA. And so, effective prioritization is vital, and effective teamwork and crew resource management has to be sort of spot on for these big complex bleeding cases.
So in terms of pre-hospital REBOA, I was trying in Europe where the pre-hospital system is quite medicalized, both with the German, the Swiss, or the SAMU, but there's doctors and advanced practitioners, where here in North America, we have very seldom doctors in the field. We have critical care paramedics. There's no pre-hospital REBOA. But as already described by Andrew Milne, there's a problem of hands. You are limited manpower on the field, and there's a problem of balloon inflation time. So unless you have very obvious, dismantling injuries or open bilateral femur fracture where you can put a zone 3 and nicely control the bleeding, you have to wait the time the additional time you spend on scene versus the benefit. If it takes you 15 minutes to get the balloon up and you are just outside the trauma center, run to the trauma center with all blood you can and all line you can. If you're farther in the field, you may have better outcome with this at the expense of a longer balloon inflation time with recirculation, reperfusion injury, etc., etc.
Dave, Steve, do you have anything you want to add?
No, I really don't have any experience with teams that place REBOA in the pre-hospital setting. The generic questions I would have were answered. How many of these pre-hospital teams are actually available? The question that I'd like to forward, however, is how do you maintain your proficiency in placing REBOA in the pre-hospital setting? Are you also doing this in the hospital setting as well? I would suspect that you're not putting in a REBOA every day out in the field.
No, exactly. It is a low frequency intervention, and we basically maintain our training by just doing more training. We have specific REBOA dummies that we do moulages with, and we sort of we have quite a thorough governance process. So any case that involves REBOA will be D&D'd. Discussed at our death and disability meeting and at our clinical governance meeting as well. There was another potential issue with pre-hospital REBOA as well that I didn't mention. it can increase the times that the balloon is deployed for, which is one of the reasons we've sort of prioritized getting down to partial REBOA quite quickly. Have packaging and transferring the patient effectively and maintaining momentum is very important in minimizing the deployment times.
So excellent. Thank you guys for coming on tonight. Thank you for helping us understand more about REBOA. Did anyone have any final comments they would like to make?
Josh, if I could, I think that the focus of REBOA has been in the trauma setting. I just want to point out that we've also used that in the emergency general surgery setting on a few occasions in patients that have had intra-abdominal bleeding from a variety of sources with non-traumatic mechanisms, including gastrointestinal bleeding, until we could get the patient resuscitated and either to the interventional suite or to the operating room where bleeding can be controlled. And I think that's where you're going to see growth in REBOA as we move forward in settings outside of trauma, but in patients that require rapid intervention to address hemorrhagic shock.
Yes, I agree with this. We had a few cases where REBOA was used intra-op for uncontrollable bleeding, for example, during a bariatric surgery or a thoracic surgery on a descending aorta or this type of stuff. There is case report on obstetric situation. We don't have obstetric in our hospital, so we don't have this. But our experience is also on very bad limb injury, gunshot in the proximal limb, where REBOA from the other side can help, getting a clear field. We got also a few cases where REBOA was used more in an ACLS context to recuperate, to have a ROSC. For example, we had a carotid transection where we put a REBOA zone 1 just to get ROSC and run to the OR. So just to perfuse, the stuff. And we'll see, the indication and contraindication, good case and bad case, a little bit settled down in the next 10 years. We are a little bit trying trial and error, actually, and we'll see.
Yeah, I think the Scandinavians are also using REBOA in non-trauma, sort of medical cardiac arrest situations in the pre-hospital arena.
I have seen the presentation of the concept. I have not seen result. But if you go for 7 French, I would say go for 21 French and put a patient on ECMO. So I don't know what's the place of REBOA in that situation is. Since if you have a refractory cardiac arrest, go on VA ECMO.
I think that the obstetrical catastrophe is an area where there's some preliminary results that are favorable. There's some case reports in the literature. There's actually a small series from South America that seem to indicate that placement of REBOA in zone 3 during obstetrical hemorrhage was quite useful. Placenta creta is an example. But again, this needs to be sorted out with some controlled trials, and I'm not aware of any large series at this point.
In that case, I think the anesthesiologist might be the most appropriate person to place one until another more assistance arrives.
I agree, but it will be very hard to do a controlled trial and to do a half of the placenta accreta balloon deflated, half the placenta balloon inflated, for example. I don't know how you're going to go through ethics with this, since both groups will have the vascular complication situation. But we definitely need more data and more as robust as possible. Probably not randomized. We'll never get randomized data on that.
I think you're probably right. And if I said randomized, I misspoke. But I think we could have some prospective trials and accumulate a greater number of patients. I know this is being done sporadically, but so far only case reports in small series are published.
Yes, I agree with you. We need, very good database, good registry, good series perspective, all inclusive, not just selected good cases, but all inclusive case. Yeah. What went wrong and what went good.
Well, thank you again, Dr. Steve Smith, Dr. David Bracco, and Dr. Andy Milne. This concludes our latest Trauma Anesthesiology Society podcast. Thank you again, Doc Matters, for sponsoring us. We'll look forward to hearing people's questions in the future.